And now I invite Professor Geavlete, who is a very senior urologist, and we have been meeting in China very often. So I introduce Professor Geavlete. He is from Romania. He is member or board member in 24 national and international associations. He is vice president of the Romanian Association of Urology. He has authored and co-authors in over 1,350 papers, abstracts, state-of-the-art presentations published in journals, national and international congresses or meetings. He has abstract books and over 300 videos presented so far. Multiple national and international premieres. He has authored and co-authored or redactor in 24 books, particularly on stone diseases. In Smith's textbook of endourology also, he has authored a chapter. So the Stone Handbook of Ulyss also, his name is there and his contribution is there. In Society International Urology, in IUCD, International Consultations 2014, again in Handbook of Endourology, he has contributed immensely. So he has been faculty in about 300 international congresses and meetings, and I was lucky to have attended many amongst them. Not 300, but maybe 5 or 6 I have attended where he was the faculty. He is reviewer for most important international publications. He has been awarded Reviewer of the Month in European Urology in 2009. He was reviewer for the most important international congresses, 60 national and international distinctions, and granted with Health High Order Commander grade offered by Romanian President. Professor Geavlete, thank you very much for sparing time and having patience, having listened to us. And now we request you to share your experience with the metric stones. These are the special situations now we are going to. Please share your slides and guide us how to manage the metric stones. Professor Geavlete, sir. Thank you very much, sir. Please come on the line.
Thank you, Professor, for your patient waiting and giving an opportunity.
Please unmute, sir. First of all, unmute, sir. You're not audible.
Good. It's okay. I don't know.
Sir, you go to your, you close this window. Yes, sir.
Yeah, just 1 second. Oh, yes. I think it's okay now.
No, we cannot see your full screen.
Cannot see.
We can see your computer screen, but not it is in the PPT is not open.
He is actually sharing the screen directly, sir. No problem, even it can function.
Now it's okay. You can see.
No, sir.
No.
Sir, you closed down.
Yes.
And you open the presentation
Yes.
before sharing.
Yes, you're right.
First you open in your computer presentation.
So share screen, and this one, I hope.
Yeah, now you share, sir. Yeah.
Yes.
Now you go. Now you are in the presentation, sir. Start your presentation, sir.
Oh, thank you very much. So I hope that now it's better.
Yeah, maximize, sir.
Yeah.
Yeah, great.
Yeah, we can see now. Great.
Perfect.
Sir.
Thank you very much.
Yeah.
So once again, it's a great pleasure to be with you. So I was so impressed by the presenters. As you know, I am a ureteroscopic man, but I participate in this meeting with great pleasure. I'm so honored. And of course, I put here the Preeti Urology Kidney Hospital, your hospital, and I congratulate you once again for your real wonderful, wonderful webinar. So if
Thank you.
we discuss a little bit about this metric stone in my department, we can see that this metric stone it's really rare. And if you look to our experience, we have more than 18,000 ureteroscopies until 31 December 19, and of course 5,000 digital. But if you look to this Pcnl, it is true that we have more than 8,000 Pcnl in our department, and it is true also that the number of these PCNLs are not growing because we have here our experience in flexible ureteroscopy, and the ureteroscopy, generally speaking, it's about 1,800 in a year. So this is our main area of interest. But I choose for this presentation metric stones because they are very rare types of urinary calculi, and we have in our experience 71 cases. That means about 0.26%. And if you look to the literature, we can see that it's around 1% of cases in this situation they had matrix calculi. So we will discuss only about the pyelix or calicial projection. And if you look to the first reported case, it's already 112 years ago when Gage and Bill described this very, very special matrix calculi. So if you look to this, to our cases, to our experience, generally speaking, flank pain, I mean renal colic, is the most important and frequent. Hematuria, it's also present, and pyuria, I mean recurrent urinary tract infections. And in our experience, we had more female, 68%, and our experience also proteinuric patient we had with glomerulonephritis and dialysis in 11%, and these matrix stones rare and difficult to diagnose due to the lack of single specific signal test. If you look to our experience also, I mean to our imagistic system, we can see that radiographic examination, I mean, you can see that the majority of these stones are radiolucent, so it's impossible to see using this radiographic, simple radiographic examination. Ultrasound, yes, it's good, but it's not specific. Without normal hyperechogenicity of stones and acoustic shadowing through imaging appearance, very depending on the mineral composition. Yet it is true that in some cases we had some stones, I mean some region stones, but very rare. CT, non-specific also. It's contrast enhanced CT with a urographic phase. Yes, this is good. In our experience, we make a diagnosis with this special CT. MRI, yes, MRI is good also, and we apply in some cases MRI for diagnosis. And IVP, yes, we still use IVP. I saw in your experience, I mean in the previous presenters, that also you use IVP sometimes because you can see feeling defect. But you know, IVP we consider a historical imagistic system. So I think that CT or MRI is now imperative to be used, despite the price, of course. Retrograde pyelography, yes, the deep feeling we will find the filling defect. And of course, retrograde ureteroscopy, reno-ureteroscopy is the is clearly in favor of a perfect diagnosis. So our conclusions after this experience is matrix calculi. It's a surprise. The diagnosis was only made after surgery in many cases, and we can see this particular matrix calculi only in when we practice ureteroscopy or percutaneous approach. So the characteristic of these stones, it's, in our experience, Proteus mirabilis or Escherichia coli, I mean, these urea splitting bacterial organisms are the main factor. I mean, the main etiological factors. We find alkaline urine also in our cases, and of course, urinary tract infection is mandatory. If you look to this little video, you can see a stone, a metric stone, in which we applied in 2013. I mean, 7 years ago, and we applied this percutaneous approach, and you can see perfectly in the end of the day that we can remove the stone, completely the stone, but we don't need laser, we don't need anything that only to remove instruments to remove this. And finally, look to final aspect. I put here the final aspect. You can compare, perfectly compare the stone free rate after the stone free case, of course, after rigid percutaneous approach. And if you look to this case also, or also with pyrelic location, you can see perfectly that you need also flexible instruments. Without flexible instruments, it's not possible to clean all the calicial locations. You can see perfectly here how we proceed, and it's clear that this kind of instruments, I mean, flexible instruments, are mandatory in this situation. And if you look to the end of, in the end of the day, you can see perfectly the stone free in this specific case, of course, with matrix calculi. And of course, the stone analysis is very important, because we will see in this, in our cases, we describe exact 64% protein. I mean, hexosamine, in 12% inorganic ash, in 10% water, and 5% glucosamines. And I put here some aspects, some histological aspects of these particular stones. So protein 2/3 of the composite of the stone, and of course the main component of carbohydrate is hexose and hexosamine, and the protein component, the most common amino acid that I put here, this kind of amino acids. So look to these cases. I put some of our cases. I told you that we had not only pyrelic, but also ureteral and bladder stones. And of course, I have to say, after this experience, more than 25, 30 years, I had to say that the complete removal is mandatory only in percutaneous approach. I like a lot ureteroscopy. I like a lot flexible. We have more than, I told you, more than 5,000 cases and more than 18,000 cases in ureteroscopy. But in this particular situation, I think that percutaneous approach is absolutely imperative. We try in 2 or 3 cases, yes, to use flexible ureteroscopy. In selected cases, yes, the clearance of smaller volume of stone is possible. But once again, the king in this particular stone is percutaneous approach, and that's why I choose, for you this presentation, of course, for this particular case. What I can say, what I can conclude, matrix stones, low recurrence rate, only 5% in our series. So this is a good news. Once of the stone is completely cleared, the patient has the chance to have a very good evolution and follow-up. What is important for us is urinary tract infection. This is very important to be followed and to treat exactly the infection. I mean, in our experience, these stones seems to be caused by urea splitting bacteria rather than metabolic disorders. In the literature, there are so little references about this kind of stones. I mean, there are so I put our experience in some chapters in books that were already published, but really, it's a very special stone. So finally, I think that this international webinar, organized, of course, by my very good friend, Dr. S.K. Pal, and of course, Dr. Chandra. And I once again, I thank you very much. And I put here two of our meetings, with Pal. One was in Shanghai. He's here when operated together, demonstrative operation, and it was very nice. I appreciate a lot this kind of, and of course we had a lot of meetings together, and this was in Athens, very nice meeting, also international meeting, I mean SIU meeting. Once again, thank you very much for your kind invitation, and I hope that this presentation was focused on this particular stone in which Pcnl, I mean percutaneous approach, is the king of the correct treatment of this stone. Thank you very much once again.